was curious, like, if it was. Yeah.
I just realized that I haven't done it.
I'm gonna wait here. She's not gonna come back. She's already down the hallway somewhere. I guarantee you.
Yeah, right now.
Yeah, and it'll be helpful if one of you guys do that one because they'll, yeah, Joelle will know.
I mean, you did it last year. Yes.
I think it's a mix between like everything. And people say he looks exactly like me. And I've never heard of but we're gonna leave it that way because you're part of the minority, so I'm gonna let it be prolonged. So glad.
Like, I was literally in the show watching my couple. No, I got the email too.
Okay, so we got physical critical care unit.
Terrible.
And then.
I can't do it.
Trauma surgery.
I actually requested that. I don't think anyone's here. Oh yeah, because Robbie's not. Maybe somebody should.
Yeah, I don't remember that either. He rolls. He like really wants to say it. I think he wants to. What? She's scared of her. Well, you didn't see me sometimes. Yeah, you didn't see me sometimes. Guys, that's what I think it was funny. I'm so used to doing it.
Say
Trauma surgery.
when you are.
But yeah, it's
Someone is.
Because I would consider this. And then,
so with this.
and then these, and then
So we have 20%, so this is what you're looking at, outpatient 20%. So like we're saying like while they're on those rotations, that's how much clinic we do. I can put it down zero. That's just what we have for general surgery.
I think that it will be okay to do it because I mean, for instance, emergency general surgery like appendix and gallbladders, and many of those are outpatient surgery. And also, some of the patients that we see in trauma are outpatients. They never get. They're not. So you can.
Well, okay, so research is part of the graph that we have to do. I don't know, I know that like, I want to do some research, but like, I like 5%. It's not like there's a requirement.
They're in a meeting. They started at 7.
Secure trauma.
Yes. But I don't know when said meeting is ending.
I would always like, are they like, so my comment.
It's just asking you, is there research? Some of them.
Got it. I tried so hard. Can you grab my cup right behind you?
Your chair.
Thank you. I know.
Yes, you can sit in the front. Yeah. Oh, no. I can hear. We're just sitting. Don't be afraid.
Maybe I'll get Dr. Kramer.
I mean, like, absolutely. Yeah, so many patients around you. What do you like?
I'll be here for the talk later.
I'm sitting here walking if you want.
All right.
So to counter the, yes, okay, good. I'm gonna try to get people in and seated, so we get started on time. So this morning we have the Edwin P. Lehman Lecture, and our guest speaker is Dr. Shanda Blackmon. And first I'm gonna give a brief review of who Dr. Lehman was. He graduated from Harvard in 1914, so a little while ago, trained at the Brigham and then Barnes Hospital, and then he was the professor and chairman of the Department of Surgery and Gynecology from 1928 to 1953. So that tells you how long ago this was when those were combined. Some of you might remember SGNO as a journal once upon a time. He was known for his encyclopedic memory and his great ability in expression. He was a superb mentor and devoted physician, adored by his students, staff, and patients. And his contributions to the Department of Surgery broadened and improved teaching programs that are still in effect to this day. He was particularly interested in cancer and was the director of both the Virginia Cancer Foundation and American Cancer Society, and he was awarded the John Shelton Horsley Award in 1948 for his achievements in cancer education and prevention in Virginia. And he passed away in 1954 as he was heading to his college reunion at Williams College. And so today's visiting professorship is in his honor and memory, and I'm pleased to introduce to you Dr. Shanda Blackmon. Dr. Blackmon and I go way back. We met when we were both doing our residency / fellowship in cardiothoracic surgery in Houston, and we became instant friends, and have gone through many of life's adventures together over the years. Just a little bit more about her officially. She is the Olga Keith Weiss Endowed Chair of Surgery and Professor of Surgery at the Michael DeBakey Department of Surgery in Houston. She is also the executive director of the Baylor Lung Institute and is part of the Sugar Baker Division of Thoracic Surgery. There's a lot of eponyms there, Shanda. Her career, and again, we started together in Houston, and then she was recruited to start a thoracic division at Methodist Hospital in Houston, where she was the chief for 8 years. And then she was recruited to Mayo Clinic, where she was a professor of surgery for 10 years. And really brought a lot of innovations to Mayo Clinic, both in digital platforms, but also in her complex esophageal surgery work. She has been back now at Baylor for a couple of years, back in Houston, a little bit more of her preferred climate. And she has an extremely impressive career. She's got multiple patents, over 200 published manuscripts. She is an examiner for the American Board of Thoracic Surgery. Some of you have even had her as an examiner, I think. She's a former president of the Women in Thoracic Surgery. She's presently the vice president of the Southern Thoracic Surgical Association and will ascend to presidency in a year. She's an author of a book called The Support Group. She's an artist, a mother of 3, and a tremendous innovator. She's been an early adopter of back surgery when we didn't learn it at all during training, and she adopted it, became an expert, and started teaching people around the country. And what she really loves the most is dealing with complex esophageal problems, and that's one way she built her career. She went around Texas saying, send me your worst cases, I'll take care of them. And she built this expertise that I think no one else in the country can parallel. And today, instead of the topic that's listed for Grand Rounds, we took a vote last night at dinner and we decided that she should instead talk about complex esophageal intervention. And that's what we're going to hear about this morning. It's my pleasure to introduce Dr. Shanda Blackmon.
Thank you, Linda. It's always fun to be introduced by one of your best friends. Very complimentary. I would say it wasn't really decided until late last night after a very competitive ping pong game when the decision was ultimately made to change my topic. So I apologize if it's not perfect and right on time. I usually do rehearse these a little bit more, but the talk that I was going to give, I think I've thrown a couple of slides in. I was the medical director for the consumer digital platform at Mayo. So we built all of the digital properties that went out, the public-facing mayoclinic.org, which had 1 billion hits every year, and the Mayo Clinic app, which a lot of you may or may not have used, that rewrites MyChart code modules from Epic, and then an employee app that we spun out, and then a knowledge platform that was managed by Adobe. So I was going to talk about that and some digital research, but instead we're pivoting and talking about complex esophageal reconstruction. I will say, for those of you that are getting ready to go take your boards, this is a really important topic. So good to have a good fund of knowledge in this area. I don't have any relevant disclosures except for when I was building, most of us don't graduate from a program and then go out and build a program immediately or become chief of a program on your first day of work. So one of the things that I found particularly challenging is taking all these complex cases on and trying to manage the patients. And so because I have a master's degree in public health, I felt very comfortable building up what became a support group, but also worked as a focus group to try to determine how to best manage these patients. And so I did run that support group for the whole 8 years that I was at Houston Methodist. And now I run virtual support groups on a variety of different platforms. And I did publish a book on that topic. So some of the stories from these are in this talk. And so by the end of this talk, you should be able to list all of your options for esophageal salvage. You'll all be experts in complex esophageal reconstruction. And you'll be able to list various conduit replacements and their alternatives and review the advantages and disadvantages of each of those options. So this is just an outline of my talk. We'll start with salvage. What things can you do to prevent from losing your conduit? What can you do to salvage whatever may have been done so that you don't have to trash the conduit and divert the patient and start all over again? But when that has to happen, I'll take you through what your different alternative routes are, and then we'll go through some other complex reconstructions. This is a paper that just came out last year in Annals, and it was one of the highest read articles in Annals of last year. And I think it's because we don't have a lot published on this topic. I don't think it was because it was so great, but it did really cover a broad spectrum of all the different reconstitution of esophageal continuity options. And this is that figure, and my whole talk will go through this figure as we progress through different options. So we'll start with esophageal salvage. When I was at Mayo Clinic and I had first arrived, we had the practice of patients. Raise your hand if you've seen a patient with achalasia. Okay, so raise your hand if you've ever done an esophagectomy for achalasia. So why do we take out an achalasia dilated mega esophagus and then replace it with another aperistaltic bag? That never made sense to me. We just added a ton of morbidity with an actual mortality risk on a patient. So I started working with our GI colleagues, especially Chris Gestout, who had invented the endo stitch. And we worked out a new technique called the POPE, the per-oral plication of the esophagus. And this technique basically takes a patient with a big sump. You have to go in and do a POEM or a myotomy, surgical myotomy. You have to relieve the area of obstruction. But once you've done that, you still have this big baggy conduit. And you can see it looks like a kitchen sink trap where it dips down, food collects, and it can't really empty very well. And so we came up with this technique, which is basically going endoluminally, tagging the area that we're going to plicate with an argon beam coagulator, and then using the endo stitch to plicate it. So and when I was in college, we used to do this thing called smocking. Raise your hand. It's very popular in the South. It's where you pleat the material. It's basically the same way that you fold a diaphragm in when you're doing a diaphragm plication, but you fold the material to create a smaller sized conduit. So here you can see the different tagged areas. We'll basically close all of that by doing an endoscopic suturing technique. And this was first presented at the General Thoracic Surgery Club, which is a group that actually Dr. Martin is now president of. And we would have mostly advanced surgeons presenting different projects. And we created this animation to describe the procedure. And it basically shows how we would plicate and then cinch in with the cinch device and plicate the entire lumen to straighten it out. Now, this has to be repeated on a yearly basis, but if you gave me the choice of going through an esophagectomy and replacing a big baggy conduit with another baggy conduit that's also aperistaltic, I think I would choose a yearly endoscopy instead. There hasn't been any major morbidity reported with this technique, and we have a lot of patients that are now coming to Houston for this, and all of our complex GI surgeons are trained in this technology. We've also salvaged a conduit that was made out of colon, as you can see, and I'll try to do the pointer. This is a patient who had a colon interposition for esophageal atresia, and he had a stricture at the bottom. So whenever I bring patients into my clinic, the first thing I do is draw their new anatomy, because most of the patients coming to my clinic don't have normal anatomy and haven't undergone a textbook surgery, and they're coming with the complication, and I find that it's easier for me to communicate through drawings and illustrations. And so we basically laparoscopically went into the stomach and fired a stapler with one limb endoscopically up into the conduit and the other limb into the stomach, and we elongated or opened with the stricturoplasty, and then we endoscopically plicated that upper area. So we were able to salvage that colon conduit for that patient. This is another patient who had a redundant conduit. She had esophageal atresia as a baby and had whole stomach pulled up. And you can see that she had a lot of pooling of barium in that dependent area, and it was a very big stomach conduit. And so we went in and did a redo thoracotomy, and we externally plicated it rather than trashing the whole conduit. Sometimes people come with an esophageal stricture. This is a patient who came to me with a stent inside their esophagus, and they had a gastric conduit. It basically was likely an ischemic tip of a gastric conduit, and it was deemed to be an undilatable stricture, meaning that it would get dilated, and then a week later it would stricture off. So sometimes the surgery is not always the best option. And in this case, we taught the patient esophageal self-dilation. The patient travels with the bougie. They just put it in their suitcase. And every morning they wake up, they brush their teeth, they swallow the bougie, they pull it back out, and they go along their day. And this is great for patients with caustic ingestion, undilatable strictures, or people that you just never want to touch with surgery. And at the bottom, I put, and I'm happy to share my slides with Linda. I have them on an external hard drive. But this is the reference for a video that's actually made through MD Anderson that's online that we show our patients. Sometimes patients come with a conduit that's not working. This is a patient that I wrote about in my book who came to me when I was at Mayo Clinic, and he was unable to swallow. His surgeon basically said, listen, esophagectomy is a really tough surgery to recover from. You just need to learn to live with it. And the patient was aspirating, missing days of work, having massive aspiration events. It resulted in him being hospitalized. And when he came to me, he was suicidal. He'd already had one suicide attempt. And we were able to do an esophagram and an endoscopy, and we could identify the swirling of right here with what we determined was a 180-degree twist of his conduit, which completely closed off his conduit, which is why he was malnourished and why he wasn't doing well. So we took him back to the operating room, cut the conduit in half, and untwisted it. And this is another paper that's written by Jim Lukatich and his group showing how you can salvage different conduits that have already been presented or had a surgery from an outside institution or your own institution. Some of those are paraconduit hernias and some of those are redundant conduits. Here you can see a patient has a pylorus that's obstructing the entire conduit, and it's become big and bulky, and you can see another area that's bulging there. And this is a paper that we published with Carlos Puig, who used to be here in Virginia for a while. We had a new technique. So I had 3 patients that were sent to me for a paraconduit hernia that re-herniated after a prior repair. And the re-herniation was happening with colon going up adjacent to the gastric conduit in that area where the gastroepiploic was. And we thought, well, you can't really 360 plicate around the conduit because you'll make your conduit blood supply ischemic. But we came up with what we called the hot dog technique, where you basically almost like you're making a fundoplication. If it's a big part of the conduit right here, which usually it is larger, it's not tubularized until it gets up higher. And we plicate inside the blood supply and fold the stomach out by putting an involuted area of the conduit blood supply inside that area. And then we can 360 plicate it all the way around the diaphragm. And we haven't had any recurrences when we've done that technique. It's also important to make sure that you do some type of ICG to make sure that you haven't pinched off your blood supply by doing that. and make sure that your conduit remains viable after you create that tubularization of the blood supply. So there are other areas that you can do assisted emptying. Again, this is another patient that has pyloric obstruction. And when patients present with pyloric obstruction, most of us, raise your hand if you cut the pylorus when you do a minimally invasive esophagectomy. Nobody. So raise your hand if you do esophagectomy. Okay. So I think most of us have gone away from doing that. And the reason why is because if you cut the pylorus for an esophagectomy, the patient gets bile acid reflux, which is one of the worst things that a patient can ever suffer from. And only about 10% of patients really need to have anything done to their pylorus longitudinally. So I prefer to figure out what that 10% is after the Botox is worn off. So I give everybody Botox. Some people don't even do that. And then occasionally they'll present like this with the dilated conduit and a tight pylorus. And those are the people that we send for a G-poem, which is an endoscopic poem of the pylorus, or we can do a revisional laparoscopic pyloromyotomy or pyloroplasty. And then, of course, you want to get rid of that redundant conduit. Depending on what the circumstances are, you can either reduce it with a laparoscopic or robotic approach, or you can do plication, like I showed you earlier. And this is a patient who came, another patient that had a twisted conduit, a very well-known surgeon who gives a lot of talks on this topic, sent me this patient. He was from Mexico, and this is the patient that we actually went to untwist it, and instead, because he had such horrible reflux, we brought a root limb up to the terminal end of the conduit after we divided it in half. And this patient, I'm continuing to follow this patient, and they're doing very well. So now we'll go through esophageal replacements. So there are a lot of conduit alternatives for the esophagus. And although this topic seems overwhelming and completely like drinking from the fire hose, I'm going to try to make it easy and digestible. So first, let's start with the stomach. So stomach is the standard of care. Most of you have seen a gastric conduit at some point in your training or do it routinely in your practice. The blood supply is standard on the right and left gastroepiploic is a pedicle that supplies all of the blood supply to that conduit. I like to do a thoracic anastomosis with a circular stapled anastomosis or a linear stapled side to side. The hand sewn anastomosis has really grown out of favor because of the high stricture rate that we published back in 2005. And you can bring your anvil out through the center where you're going to have two overlapping staple lines, or you can bring it out by the side where you only have one overlapping staple line. I think both options work. So when we started standardizing how we do our anastomosis, how we do our esophagectomy, going into the program, we were a 3-star program, high volume, doing about 125 esophagectomies a year. But we wanted to do even better. And so I started looking at safety in the operating room and standardization of practice. And I know Dr. Martin has presented a lot of data on how she created an ERAS program for lung resections. So this is our protocol, and it's not meant for you to be able to digest all of this. It's just meant for you to be able to see we have a standard protocol for going into the operating room and briefing before the case is even brought into the room. Then we have a separate timeout standardization for how we go through everything meticulously before anyone cuts skin. And then we do a debriefing. At the end of the case, I stand in the room and I announce, we are now doing a debrief. And I start the debrief with, is there anything that I could have done better? And I make up something, even if I could, I rarely think I did a perfect job, but usually I'll say, I think I could have discussed this case with the patient a little better, or the resident, or maybe I should have been a little bit better at the way that I mobilized the stomach, or maybe I should have communicated this with anesthesia better. Everybody openly goes around the circle and talks about what we each could have done better, creating a level playing field. And then there's always the post-operative handoff that's so important. Standardizing that as well is really important for creating continuity of care. So Joe Duraney, who's a cardiac surgeon and a former president of STS, introduced to me the Blue Angel debrief. Raise your hand if you've ever heard of this. Okay, good. So this is the structure of a Blue Angel debrief, and it's done at the end of every surgery. You have to make a feeling statement. It's not who's right, it's what's right. You have to have a mentality of having safety, saying, I'll fix it. So what happened? Why did it happen? And then you need to acknowledge. So what will we do different next time? And you use the word we, not I or you. And then you always want to talk about being glad to be here, exuding gratefulness and humility. And then, oh, by the way, so talk about some near misses that may or may not have happened. And this is another article that I recommend everyone read, even though it's very old. It's from 2001. And this is our team. The first time I used this article, it's written by Amy Edmondson, who's an expert on the safety of the team. And this speeding up team learning looked at cardiac operating rooms when off-pump bypass was starting. And she looked at two different mentalities in the operating room. One where it was a very structured hierarchical system where the surgeon was always right and people were afraid to give feedback to the surgeon, and it was sort of a command central structure. And the other one was written as if the other room that she studied was more of a level playing field, more like the Blue Angel debrief where everyone can speak up and there's a culture of safety. And she talked about how one was successful and why the other one wasn't. Now, going back to operational efficiency, enhanced recovery, and pathways, we don't have enough time to go into this in detail, but I wanted to talk about some of the frameworks that you can employ in your own institution to do things like this. This is called the DMAIC framework, and it's define, measure, analyze, improve, and control. And we use this framework to go about, even though we were a 3-star esophagectomy outcome institution that was high volume, how can we make it even better? We looked at our data and we noticed that we had a really high ileus rate, and about a third of our patients were going into AFib after esophagectomy, and we thought that was too high. So we built the pathway. And again, this isn't meant for you to be able to read all parts, but you can see how structured and detailed it was. Anywhere from where they first present to when they come into the pre-op to when we're actually in the surgery, and then going through a goal-directed therapy algorithm, even into the operating room, placing a hemisphere and building a computerized algorithm for how we manage fluids, how we manage postoperative hypotension, making sure that we didn't fluid overload the patients, and meticulously monitoring every step along the way. This is the postoperative algorithm. We developed like a nausea ladder. We've developed protocols for everything that might happen after surgery. And all of these protocols were initiated and instituted. And after 1 year, so we used historical controls, about 250 patients that were historical controls that we studied, and we put 58 prospective patients through this protocol. And only after 1 year, we were able to reduce our overall complication rate, we dropped our arrhythmia rate, and we dropped our postoperative ileus rate to 0. So it was a great implementation, an example of taking a good program and trying to make it even better. So what if the pathway doesn't apply? What if you damage the gastroepiploic? You've got this patient on a pathway, you think it's just going to go along, but things don't go according to plan. Raise your hand if you've ever heard of a reversed gastric tube. Okay, so this is, I had to pull this out of the archive because Linda, I think you called me once and said someone had called you and asked, what do you do if the gastroepiploic had been damaged? I don't think you had damaged it, but somebody was calling around. And we have this network of friends and we start trying to group think on how to solve problems. And this is basically one way to salvage it. So obviously, if the patient has an undilatable stricture, you can use this. If the patient has cancer, you cannot do this because you're leaving that top part of the conduit. So it only applies in certain circumstances, but it is an option. So now what about a free jejunum with stomach? So this is not just a free jejunal interposition, which is the third group I'll talk about, but this is perhaps a gastric conduit that you meant to use, but the top part became ischemic. Or you used it and the conduit became ischemic and they leaked and you had to divert. So as a resident, I was concerned about understanding how far will a particular conduit reach? How far will a Roux-en-Y jejunal conduit go up? So I basically had this illustration drawn by an artist and then drew out how far each conduit will reach based on the degree of territory that you have to traverse. So the lower thoracic esophagus can usually be replaced by a Roux-en-Y jejunal limb. Once you get up above 34 centimeters, you're going to be looking at needing a gastric conduit. And you really never want a gastric conduit to go low below the trachea. You really want your gastric conduit to always be pulled up above the azygos vein. Does anyone know why? If you have a whole stomach and you bring it up low, you'll have terrible reflux. So the goal of a gastric conduit is always to bring it very high above the level of the azygos vein. And then anything up near the mandible for laryngeal reconstruction, typically you have to have a supercharged jejunum or a colon interposition to reach extremely high. So it also depends on the Siewert classification, which is based on where the tumor is in relation, the epicenter of the tumor in relation to the esophagogastric junction. If you have an epicenter that's below the EG junction, that's treated like a gastric cancer, and you know you're going to be doing a gastrectomy, and typically you'll be reconstructing with the Roux limb. But anything higher, you'll be targeting a gastric conduit. And sometimes patients will come to us, and we aren't really sure what they had done. Maybe they had a gastric conduit pulled up, or they had esophageal atresia as a child, and we have no operative note and no way of knowing what our substrates are that we'll be using to reconstruct with. And so we've developed and published a protocol of doing arterial and venous 3D reconstruction to determine, do we have adequate jejunal arcade? Do we have adequate gastroepiploic artery to even use the stomach in some circumstances? And this is an important technique that's really helped when we don't have an operative note. Uh-oh, not advancing. Oh, and then it advanced too fast. So this is a patient that I was called in to help with the case, and they were worried about the gastric conduit. And this was an open esophagectomy. And so we performed intraoperative ICG. Raise your hand if you've ever seen intraoperative ICG. Good. So here, when you look at the perfusion of this conduit, it looks quite robust here. You can see the gastroepiploic and then these perforating vessels coming through. But this is the tip of the conduit, and it's black. Raise your hand if you would use that conduit. If you used it, I think you'd be terrified that it's going to all fall apart. So basically, the tip of the conduit wasn't long enough to reach for the length that was needed. And so that was the day that we came up with this jejunal interposition to bridge the gap between a gastric conduit and the esophagus. And that's a nice technique that can be used in some circumstances. So whether you have a necrotic conduit, an undilatable stricture, a prior Roux, one of the biggest cases that gets sent to me nowadays is patients who develop esophageal cancer after gastric bypass. So if you've had a Roux-en-Y gastric bypass, that's actually the easiest esophagectomy you'll ever do if everything's like it's supposed to be, because they've been ischemically preconditioned and your conduit is frequently healthier than it would be normally. But if they've had a sleeve gastrectomy, those patients have had the greater curve thrown away and removed. And you often have to do a jejunal interposition for those people when they get done with their neoadjuvant treatment for esophageal cancer. So these are indications for alternative conduits. Sometimes you'll have patients who have tumor that goes all the way up the esophagus and down into the stomach, and that's extensive tumor. Sometimes the conduit doesn't survive, or sometimes the gastroepiploic's been damaged and you can't get it to reach, even if you do the reverse tube. Or sometimes patients are just resected in an emergency situation and they come to me diverted. This is a patient that was referred to me with a dead colon interposition. One of the problems with colon interpositions is not the arterial blood supply, but instead the venous drainage. So there's a lot of venous stasis, and that's what leads to necrosis of the colon conduit. And sometimes you'll come up with a colon interposition that has senescent lengthening, where it's like a river and it becomes redundant, and you end up having to reduce some of the redundancy to make it optimal. But in this case, there was a dead colon interposition. And sometimes patients will come with tracheoesophageal fistulas. So they had an esophagectomy, the top of the conduit became necrotic, and typically they got stented, but there was nothing in between that perforation and the trachea or the bronchus. And Dr. Martin wrote a beautiful paper, I think in 2005, about what do you do when you have a terrible leak. And she talks about the importance of putting muscle in between the leak and the conduit, because this will happen if you don't. And so I actually have had probably 25 or 30 of these cases sent to me where they had a robotic esophagectomy, more common than VATS. And I think that's because of the lateral thermal spread of the robot and the early experience of surgeons. So typically it's a surgeon in their first 50 cases or an institution that's just learning robotic technology, and they aren't really fully comprehending the degree of lateral thermal spread when they're doing the robotic esophagectomy, and they end up with these terrible conduit fistulas. So just to review these, the first thing I do when they come to me is you divert the esophagus. You do not try to divert. You do not try to resect and reconstruct all in one sitting. And a long time ago when I was at MD Anderson, we did several of these cases, and I was taught to divert underneath the clavicle. So if you divert an esophagus, raise your hand if you divert off to the side under the clavicle. Good, nobody does that anymore. Oh, Dr. Carrot was starting to raise his hand. So maybe I can change your mind with this lecture. So I used to do the same. And then when I went to reconstruct, you have to make an incision here, but you end up making an elliptical incision around your diversion. And now you have this T incision that looks terrible. It creates a terrible wound. And so now instead we bring our conduit out in line with our future incision, and it makes it much more elegant. So you're always planning for what will happen 3 or 4 months down the line, not just planning for the surgery that's at hand. And then what if sometimes I get patients who had a cervical anastomosis, and the cervical anastomosis, when you take it down and you remove the conduit and you go to divert, you barely have enough esophagus to reach. So we've started looking at ways with our plastic surgeons to create a tubularized conduit that will allow us to divert the esophagus in a meaningful way, especially for patients who need to get adjuvant therapy or who need to get well enough so that they can go on, and maybe 6 months later on down the road, we'll create a new conduit for them. The more comfortable you make the conduit, the better the patient is and the longer they'll wait for the reconstruction. You want them to be training for the reconstruction like they're training for a marathon. Good nutrition, good ambulation, optimal circumstances. They've received all their adjuvant chemotherapy or immunotherapy. You want them to make sure that they don't have ongoing active cancer before you do the reconstruction. And so you need to create a really comfortable diversion for them so that they can tolerate it while they're going through all these steps before you reconstruct. So I do advocate for patients that or for providers that are sending patients to me. What used to happen is they would divert the patient and then send me the patient. And now I ask, if you're going to send me your patient, please send it without the diversion and let me divert, because I'll put it in a certain location where I know I'm going to make that incision to reconstruct. It also helps because then I can perhaps bring in our ENT colleagues. We do recurrent laryngeal nerve monitoring. If somebody loses their recurrent nerve, it's a huge problem when we do a jejunal reconstruction, because now they're hoarse, they aspirate, they have a hard time managing their secretions, and then you put a peristaltic conduit up to there, and they have to completely change the way that they swallow. So protecting the recurrent laryngeal nerve is one of the most important things when you start talking about diverting these patients. Then when you reconstruct, you can take a couple of different routes. You can go in the anterior mediastinum, which is really like right behind the sternal bone, or you can go posterior mediastinum. But if you're delaying it and doing it in a staged approach, you're losing that posterior mediastinal route, and almost always your patients will have an anterior mediastinal route. And then when you pull that conduit up, it's a pedicled conduit at the bottom, and so you can go in front of the colon or behind the colon, and I'm currently doing it in front of the colon. You go behind the colon if you need additional length, and then you could also go subcutaneous. And this is just another view of what that looks like with an anticolic on the left and a retrocolic on the right. and this is the jejunum pulled up. And you can see it's a little bit ischemic up in this area because it hasn't been supercharged yet. And this is a patient that was sent to me from Georgia last year. He came in with an undilatable stricture. He had an aortoesophageal fistula and an esophageal diversion. They had repaired the aorta, but he needed to get reconstruction. And the patient was so malnourished, we actually ended up sending him home. He had a little bit of stomach left, which you can see right here. But he was a very thin man and he had loss of domain. And the anterior mediastinum was not around anymore because he had his ascending aorta replaced. And you certainly didn't want to do a median sternotomy with an aortic conduit in the way. And imagine if that leaked all over the replaced aorta. That would have been a nightmare. And so this is one of the only subcutaneous conduits that we did. But in the middle of the operation, when we were bringing the subcutaneous conduit up, we realized there was no domain and it was going to become occluded right at the costal margin. And so we had to create a VRAM flap from his abdomen and reverse it and put it in here to create domain for the subcutaneous conduit. So this guy is at home, eating, drinking, back at work, doing very well. Sometimes things don't go down so well, and so he can actually milk his conduit down, which is, I think, kind of neat. I might be the only one that thinks that's beautiful, but and then here's a free jejunum from left internal mammary artery and vein going to just a little jejunal jump graft connecting the esophagus to the stomach. So for those of you that are, I see Leora in the audience. This might be exciting to you because I'm showing you a mammary pedicle here. So this is a really good solution if you just have a short distance that you want to bridge. So a lot of these patients would get sent to me with a dead gastric conduit, and we wanted to figure out how can we use that piece of stomach without throwing it away and without rerouting everything. And just taking a small piece of jejunum is a lot less of an insult to a patient than taking a big roux limb and bringing it all the way up. And so these are three of the surgeries that we pioneered. So over to the left, this is a mammary-based free jejunal interposition. This is a gastroepiploic-based free jejunal interposition, which I would recommend maturing it in the abdomen before you bring it up. And this is a patient that we tried to bring it off the mammary, but the jejunal interposition wouldn't reach. And so we had to cut the mesentery in half and then bring the lima over to that little bit of pedicle. So it sounds complicated, but it's not. It's the same as the supercharged jejunum. And I'll show you some pictures from that case. So this is the actual length that the stomach would reach. There's no way that's going to reach to the terminal esophagus. And so here's that section that we supercharged. So here's the artery vein anastomosis. Here you can see your gastroepiploic, which is the source, and this is the half of the gastric conduit, and this is the jejunum. But then when we went to actually pull it up, it didn't really reach. We let it, let's see if I can go back. We put an internal Doppler, we let it mature in the abdomen, and then we brought him back, and you can see, here's the part that's got rich blood supply. Here's the part where we divided it up to the mesentery wall, and here, this needs to be supercharged. So this went into the mammary, and ultimately, this is what he looked like. He had a tracheostomy, he had 2 internal Dopplers, and then we did a little skin graft over the area. And here's the skin graft with the mesh over it. So that's the jejunum plus stomach. Then you have free jejunum, which sounds really simple after we just went through jejunum plus stomach. And that's usually for a high cervical esophageal cancer, where you just have to take a small discrete area out and you bring a jejunum free graft. That's usually off the transverse cervical artery, but you can certainly use any of the vessels in the area that you might need. And then this is a patient that developed residual esophageal cancer with a colon interposition, and we didn't want to redo the colon, so we did a little jejunum in the middle. And this is another patient that had an undilatable stricture, and we replaced that upper part with a free jejunum. And then there's pedicle jejunum. So that's probably what you're more used to when you do a gastrectomy with a D2 lymphadenectomy. You use the roux to replace stomach. This is a patient who had a stomach intact, but then had a jejunum coming up as a roux limb that we reconstructed. This is the Marandino procedure, and that's where you keep the vagal nerves intact. but you just bring a jejunal discrete limb up and you can connect it to the stomach. And then the supercharged pedicle jejunum. And that's really for patients where you can't use a gastric conduit. It's nice because it doesn't require formal bowel prep. It's usually free of disease. It's similar in diameter to the esophagus. It has intrinsic peristalsis, and it doesn't undergo senescent lengthening like the colon does. Unfortunately, the ratio is 3-to-1, so you have to unfurl the small bowel when you're bringing it in. But you can get adequate length when you unfurl it, like you see in this picture. And this is just a review of the literature of all the published jejunal interpositions that have ever been done. I've done collectively in the different institutions, probably over 100. And the mortality rate is almost always under 10% in most series, with about a 0 to 30% leak rate and about a less than 10% graft loss. I've only lost one graft, and that patient had an antithrombin-3 deficiency. He lost his gastric conduit and his jejunal conduit. He kept clotting them off. So this has been reduced down to 20 steps. Not enough time today to go through this in great detail, but I do have it on a YouTube channel that you can go to, and it walks you through it step by step. And we offer a program where you can come down and observe. We'll do 2 in a row back to back, so you can see 2. We just did this with the University of Minnesota. And then I'll come and observe, and our plastic surgeon comes with me, and we sort of coach you through it. And that's been a really fun program that we've done in multiple institutions trying to spread the technology. So this is a patient who had a prior sleeve gastric bypass with the early esophageal cancer, got neoadjuvant chemoradiation, and then underwent reconstruction with an anti-colic roux and then supercharged segment up here off the left internal mammary artery and vein. This is a patient who had an extensive tumor going all the way up into the esophagus and down into the stomach, got resected, diverted, and then reconstructed with what we call a delayed supercharge. And this is a patient who had an endosophagostomy with a mini tracheostomy placed for suctioning and airway maintenance. He was sent to me from Colorado, and he had 3 tracheal fistulas. So we had to do a right thoracotomy and repair the right main stem. He also had an aortic aneurysm, so we had to fix that. And then we did a median sternotomy, and we used a pedicle flap to cover the tracheal perforation. And then we went through a left thoracotomy to fix the left tracheal perforation. And then we did a supercharge. He had 3 runs on ECMO, but he's now water skiing with his dog in the boat and having a great life. And this is another video that you can reach. This is the QR code that takes you to how to do a supercharge. It's an hour-long video, but it should take you through it quite easily. And again, I'm happy to share the slides. We've also published, like I talked about, how important it is to standardize a basic esophagectomy. It's even more important to standardize a supercharged esophagectomy and reconstruction. And the supercharged jejunal reconstructions, we've gone through all the problems that happened. We've done a root cause analysis of every problem, and we've revised it. And this is published in the Annals of Thoracic Surgery for anyone that's interested, and it takes you through how we standardize that as well. These are some of the modifications that we made when I moved my practice from Methodist over to MD Anderson, and then that cumulative experience going over to Mayo. So we were doing about 70% hand-sewn anastomoses. Now we do 100% stapled anastomoses. The length of stay has gone down to an average of about 10 days, and the mortality remains 0. And we no longer do a bowel window. We used to externalize the bowel, putting it out on the chest. Patients really thought that was gross, so we stopped doing that. And now we just do an internal Doppler. These are just some pictures of what it looks like. So this is the ligament of Treitz. This is the stapled off duodenum. The patient's already had a gastrectomy, and the crural fibers of the diaphragm are usually closed. This is the first 20 centimeters of the jejunum. This is the superior mesenteric artery. We preserve that first branch to maintain blood flow to the ligament of Treitz area. And then we've standardized the way that we create our arcade. So the first branch is preserved. Our second branch goes to the mammary. The third branch is a bridging branch, and the fourth branch is kept obviously off the superior mesenteric artery and vein, but it can also be used as another bridging branch if you need to go even further. This is what it looks like when we unfurl the bowel. So you can see here, it's not unfurled yet, and this is how straight it looks after you unfurl it. This is the second branch that'll go to the mammary for supercharging. This is the third branch that's a pedicle, and this is the fourth that's kept in continuity with the superior mesenteric artery. And the mesentery gets divided all the way up to the bowel wall here. This is our standard, and this is what we do. And these are alternative options when your standard doesn't work or if the patient has weird bowel blood supply. This is what it looks like when we bring it out and stretch it out to look at the blood supply. I really recommend transilluminating it so that you can see all those arcade vessels. The thinner the patient, the better for seeing those arcade vessels. And here you can see an even more beautiful view of what it looks like. Here you've got a pedicle. Here this will go to, this is divided all the way up to the bowel wall. This is the ischemic part, and this will be reimplanted into the left internal mammary artery and vein. And this is what it looks like when it's stretched out. Again, this is the mesentery divided all the way up. All of this is supplied by superior mesenteric artery and vein. And this is just another view of what it looks like. We love to take pictures of the supercharges. They're so pretty. This is another picture. It's too many pictures. It doesn't want to advance. And then this is just a really nice view of what it looks like when we do our microanastomosis. To the left, you can see a venous coupler, and that's being used for our venous anastomosis. In most cases, we're using a 3.5 millimeter venous coupler. And to the right, this is the under the operating microscope. Right now, I'm doing these with Andrew Wong from our ENT group. Before Mayo, I did these with Samira Mardini. And then when I was at Methodist, I did these with Pierre Chevray and Mike Quebec. Anyone who's done an advanced micro fellowship should be able to do some of this, but I do recommend going through some of the training that we offer or other institutions offer to make sure you're comfortable with all the parts of this surgery. And this is just another list of the root cause analysis, all the complications or problems that we have, and then all of the solutions that were the endpoints of how we solved them. This isn't really meant for you to read either. It's just to show you we've had a lot of problems over the years. So if you're interested in doing these procedures, I recommend that you go through this and learn from our mistakes so that you don't have to make your own. We monitor with an internal Doppler flap. And this is just one of the other articles that we wrote in the thoracic surgery clinics. We looked at our outcomes with the upper digestive disease tool, which is an EPRO instrument, looking at patients inside of a year and outside of a year and looking at their pain, dysphagia, reflux, hypoglycemic dumping, and gastrointestinal dumping, showing where these patients are after years from the surgery. And then there's the colon interposition. This is good for the same indication as esophagus. In this particular patient, they had a roux limb that leaked, was stented, and the stent eroded into the colon. The patient she'd already had a roux limb, so a jejunum interposition wasn't an option. So for this patient, we actually had to do a free colon interposition, bringing it off the mammary completely. This is a supercharged free colon interposition that we had to do for another patient. And this is a long segment esophageal replacement with Ken Kessler's series. And this is an exact illustration of his series where they supercharge colon interpositions with good results. These colon interpositions can be based off of the right, left, or transverse colon, depending on what kind of anatomy is most favorable. And you can plug it into the stomach or a roux limb. The supercharged colon interposition, I think, is as complicated, but not as good as a jejunum because it's a big baggy conduit. So I definitely favor jejunum over that. And then finally, there's myocutaneous conduits. So this is my operating room nurse when I was at Methodist. She had an esophageal stricture from terrible reflux and had to have self-dilation for a long period of time, got tired of self-dilating, and so we took a free forearm flap and augmented her stricture. We used a little piece of that forearm as an indicator flap and then later took that out. But it was really nice to have somebody working in the operating room that had undergone a complex reconstruction, helping to get your patient settled. Other types of myocutaneous conduits, this is probably one of the more complicated cases that I've ever done. and it just got accepted for publication in the Annals Short Report, so it'll be coming out next month. This is a patient who had a tracheoesophageal fistula. He had 60-pack years smoking, got laryngeal cancer, had a TE phonation puncture device, ended with a fistula. They tried a pectoralis flap. He failed all local flaps. So I tried to reconstruct him with a jejunal interposition, but it fell apart because he'd had 70 gray of radiation. And this is what it looked like when I scoped him eventually. So this patient, I sort of made something up for him, which is what you do when you do these complicated cases. Because I had done 2 years of cardiac surgery, Dr. Caselli taught me how to cut down on an axillary artery and sew in an 8mm Dacron graft in about 8 minutes. And so we basically harvested saphenous vein, like you do for cardiac surgery, brought the saphenous vein up, tied the venous end and the arterial end to the axillary artery and vein, made a big AV loop like you do for dialysis, and then transected that AV loop and brought it in as the pedicle blood supply to a right latissimus myocutaneous flap that was a free flap brought all the way over to reconstruct the esophagus. So we called it a BYOB flap, like bring your own blood supply. And we actually called it that in the annals, and they didn't really like that. And then there's the synthetic esophageal replacement. I killed a lot of pigs trying to make this work. It has not worked to date, but we do have some tissue allografts that we're using to try to replace esophagus. Some people are even talking about transplants or decellularized grafts that are populated with human cells. This is an example of one of the experiments that we did where we used porcine populated with stem cells and put it in, and then put a stent on the inside to try to protect it while it's healing, because you can't put a feeding tube in a pig, so you really kind of have to somehow protect it. And this is a patient where we reoperatively intervened and salvaged with another jejunal interposition. But you can see these drawings become really complicated, and the patients only understand a drawing. They don't really understand stuff when you start using all the words and describing the cases and the presentation. So I do find that these are really helpful ways to communicate with the patients. And we don't really have time to do the special circumstances, but I know probably Dr. Martin has presented many times on esophagoatrial fistulas and esophagoaortic fistulas. Didn't you just give that talk this year at STS? And tracheoesophageal fistulas. So maybe I'll end there so that we have time enough to go through things. And this is, let's see if I can share this. This is just this is just our team, the plastic surgery partners that we work with. It's important to recognize all the team members that have played a role in helping us to do these cases. This is my operating room for Mayo, and I have a new team picture from my Baylor team. And then this is our Department of Surgery. It's 250 surgeons in our Department of Surgery, formed by Dr. DeBakey, and now Dr. Cooley's group, the Cooley Hands, have formed, Texas Heart and Baylor have fused, and so now it's all one institution. So thanks.
Shanda, that was great, and we really appreciate you being here. You can pretty much talk on anything, is what I've realized, and have everybody understand. So thank you very much. This was really incredible, and I would encourage anybody in the audience. We have a lot of students here to get to know her. She is a real wealth of knowledge and a true expert surgeon. So thanks for being here.
Thank you. Yeah, I have a lot of the cardiac surgeons ask me, why don't you consult me to do your mammary anastomosis? Why do you use a microvascular plastic surgeon? And I said, well, if you feel comfortable doing my microanastomosis and then helping me with like a VRAM if I need it, and a myocutaneous flap when I need it, then I'm happy to partner. But it is pretty complicated when we start doing a lot of these cases. And it's been, with the aortic fistulas, which we're starting to see a lot of those as more and more patients are getting endografts and they're slowly eroding into adjacent structures like lung. some of these are becoming really important to learn. At least we need, and I want all of us to have big regional centers that do these cases, because I'm not going to be doing this forever. So we need to train a whole group of people who are interested in doing these cases so we can spread the love.
Shanda, that was outstanding. And you just made it sound like this is simple. This is incredibly, incredibly complicated surgery, very high stakes, a lot of things that can go wrong. I think we've done 3 supercharged conduits here, and everything I did, I learned from you, and I have many coaching sessions before we did them. I think Dr. Bauer, Dr. Saifuddin just had to step out, and Dr. Campbell, and I think Dr. Friel and I did a colon at one point where someone had a gastrectomy gone wrong. And they all did really well so far. Things come in threes. But you know, this is the type of stuff that you just breeze through it, but it takes hours and hours of study and preparation and thinking and getting the right tests. And they're just really, really tough problems to handle. But then the patients are incredibly grateful. I was sharing with people last night that one of our jejunal interpositions, he was so grateful and thankful for his reconstruction that he invited me to tailgate with him, and he had me do a Goldschlager shot with him for his new jejunal
I thought it was
reconstruction.
a fireball shot.
Oh, fireball. Okay. Well, I think it's kind of the same, but you know, I could see the peristalsis working right through his neck. But yeah, they're really, really tough problems, and not something you want to take on lightly. Either send them to you, or have
We can do them.
or call someone and get some really good coaching in advance. But that's also been a great option to have working with our surgical oncology team, some of our complex gastric cancer cases, and just knowing that there's some little bit outside the box ways to handle the reconstruction. And again, you are credited with really advancing this field.
Thank you, Linda. That's really nice. There are a lot of students and residents in the back. The take-home message here is when you get out into practice, the best way to succeed and become a busy, active surgeon is pick something that everyone else hates. Pick the thing that everyone else cannot stand and runs away from, and learn. Just methodically go through it time and time and time again and figure out how to crack the nut or do the thing that nobody else can really find. AI is never going to do a supercharged jejunum. We are never going to get replaced by AI in that area. So I say that maybe 20 years later, somebody's going to, but by then I'll be retired. So that's okay. I think it's really important as you go out to try to pick 1 or 2 things that you can become a champion of. And I would say the worse off the patient is, and the better the intervention, the better you can make their life. It's a formula for happiness. I know everybody talks about the word burnout, and it's almost like a pandemic. The best treatment for burnout is to stay longitudinally connected to your patients. I give all my patients my cell phone number, and I get more messages on Mother's Day and holidays, mostly from these grateful patients who now have this great life, or they're having another grandchild. So a formula for happiness and success is to really pick a needy patient population, whether it's through outcomes research and you're trying to better an entire population, or through a scientific discovery that solves a problem for a rare disease. Whatever it is, I think that is the way to avoid this burnout pandemic, to really stay longitudinally tied to your patients, focus on becoming excellent and building a niche that you can call your own, and then really trying to be the best at it and trying to be creative. I think creativity in surgery is underestimated. I've made up half of these surgeries that I just presented to you today, and we come up with funny little terms to describe them. But I think it's important to recognize that just because you're taught how to do something doesn't mean that that's the way it needs to be done. You need to learn as much as you can and think, how can I do it better? But learn from history. Plenty of surgeons that I've made tons of mistakes. I'm publishing my mistakes. I actually give a big video on what happens when something goes wrong in the operating room. And if you want to see a lot of bleeding, you can watch my VAT series of me getting into trouble like 20 times and what we did for it. So learn from your mistakes and really stay focused. I think we're about to make you late for something.
Thank you. Oh,